Hello, and welcome to our next lecture in cognitive neuroscience. We're going to begin discussing cognitive neuroscience methods in more detail. Pardon me. In particular, in this lecture, we're going to talk about studying neurological dysfunction or populations of individuals with specific neurological damage. So, while there are quite a few of these to run through, it won't take us very long. We'll start off by talking about some causes of neurological dysfunction. And then we'll talk about studying brain behavior relationships following this kind of brain disruption and some of the issues involved there. Remember, one thing to keep in mind about this is, in general, these kinds of studies are case studies or very, very small n studies because we're usually talking about some sort of unique form of damage. Some of you may have read Oliver Sacks' book, The Man Who Mistook His Wife for a Hat, which is a great set of clinical tales. I highly recommend it. And so we're talking about those kind of studies, oftentimes more in-depth, more experimental in their approach. Another good book we'll talk more about later on is Martha Farah's book on visual agnosias, and so we'll spend some time discussing that as well. But let's start off by talking about some causes of neurological dysfunction. As I said, this is a pretty hefty list, but we'll run through these quickly. We're not going to do this not going to do a deep dive into these, just enough for you to understand the issues involved and what's happening there. So we're going to talk about some brain tumors, ischemic stroke, aneurysms or cerebral bleeding, subdural hematomas, effects of stroke, infectious diseases, penetrating injuries, closed head traumas, and degenerative disorders. Let's start with tumors. Brain tumors are classified by the World Health Organization by 4 grades, grades 1, 2, 3, and 4. Grades 3 and 4 are what we would call malignant tumors, generally as what we call them cancerous tumors. That is, they reproduce very rapidly. And those are the most serious and require the most immediate response. So as you can see here on the right, a grade 3 tumor is an actively reproducing abnormal cell. Abnormal appearance under microscope, infiltrate adjacent brain tissue, and they tend to recur, often as a higher grade. Grade 4, very abnormal appearance, very rapid reproduction. They tend to form their own new blood vessels to maintain their rapid growth. And in the center, there will be areas of necrosis or dead cells, which have caused part of the brain to die. Malignant brain tumors are most commonly caused by metastatic cancers, most commonly lung cancers and melanoma. Remember, the brain is one of the most vascular parts of the body. 20% of blood supply is sent to the brain. It also branches off into smaller and smaller and smaller blood vessels. And so those cancer cells from lung cancer and melanoma can end up getting lodged, essentially, in those blood vessels and then creating highly problematic types of brain cancer. Treatments for tumors include surgery, depending on the location. So if it's a topical tumor, as we might say, close to the skull, you would just simply remove part of the skull and then remove the tumor. Deep brain tumors are now sometimes accessed via the sinus cavities. So I know someone who had a brain tumor removed, which was near her hypothalamus and pituitary, and so they went through her nose and through her skull, through her sinus cavity. The other options are stereotactic radiation surgery, which include both Gamma Knife and CyberKnife procedures. One of the things about brain tumors is we get a pretty good, clear picture of brain damage. It tends to be localized and tends to be fairly straightforward. So as I was saying, the Gamma Knife and CyberKnife are procedures used to treat these tumors. Essentially, these are radiation treatments. And the idea is you use radioactive cobalt or some other radioactive substance to create gamma rays. Those gamma rays then converge on the target tissue, destroying it with the radiation. The reason we do this along many target paths is so we don't cause damage to the tissues. Excuse me. spring has sprung. We don't cause damage to the target tissues along the paths of those gamma rays. The CyberKnife, very similar, except for it's much more conducive for patients because they don't have to sit perfectly still for long periods of time. Essentially what happens is the computer's fed the MRI images from the patient, tumors localized, and then scanning devices help track where the individual might move to. They're, of course, told to keep as still as possible. But then that CyberKnife, moves its way around, irradiating the tumor from a variety of angles, as you can see here, and removing that tumor. That is a quick rundown of brain tumors. Of course, there's a lot more to that, but relatively straightforward. Generally, we talk about them generally being a glioblastoma or a meningioma, depending on where they're located. The next cause of neurological dysfunction is an ischemic stroke, which is a block of a blood vessel. So stroke or cerebral vascular accident causes a temporary loss of blood flow to the brain. This is, of course, a common cause of brain damage in the elderly. Ischemia is just simply a loss of blood flow to part of the brain, or it certainly can be other part of the body. So, for example, most heart attacks are caused by ischemia, lack of blood flow to the heart. So the most common type of stroke then is that ischemia resulting from a blood clot or obstruction of an artery. Most often what has happened is something has broken loose from, say, the carotid artery. Piece of sclerotic plaque from high cholesterol, that sort of thing, is broken off and then gotten lodged in the brain and is then causing a blood clot, blocking that blood supply. An aneurysm is an unusual injury which can cause pretty significant damage. So these next types of damage we'll talk about are some sort of bleeding within the brain itself. So when we talk about a hemorrhage, this is a less frequent type of stroke which generally results from a ruptured artery. And so essentially what's happened is a blood vessel is burst and essentially the patient is no longer receiving blood to parts of the brain because instead of continuing along the artery, it is just simply rapidly flowing into the brain, which can cause secondary damage. Neurons are then flooded with excess blood, calcium, oxygen, other chemicals, and as a result, we get pretty significant damage. You can also have what's called a subdural hematoma. This is essentially a bruise that is underneath the dura, which is, of course, one of the membranes we talked about in a previous lecture. That subdural hematoma then starts to put increased pressure on the brain, and that pressure is then what's causing damage. Finally, an aneurysm is caused by a weakened blood vessel, which bulges outward and then can rupture. Aneurysms tend to be genetic in nature, that weakening of the arterial wall. They're very hard to diagnose. If the blood vessel has bulged out, they can be diagnosed through an angiogram. Most often they are diagnosed when they rupture. And in fact, oftentimes these are very rapid fatal events, particularly depending on where the aneurysm might occur. The issue for the brain in particular is cerebral aneurysm. Again, it causes very significant damage when that blood vessel ruptures. Essentially, it's like a little bomb going off. So lots of widespread damage. Then we have loss of blood. So all sorts of add-on difficulties. So here you can see what an aneurysm might look like. So you might have this bulge in the wall of the blood vessel. It then ruptures. That then causes damage to the surrounding tissue because of that rupture. A couple things that occur from strokes. Edema is the accumulation of fluid in the brain. This results in increased pressure on the brain and increases the probability of further strokes. We also get disruption of the sodium-potassium pump, which leads to the accumulation of potassium ions inside the neurons. This is due to loss of nutrition going to the brain itself. Remember, the sodium-potassium pump uses a molecule of ATP. Each sodium-potassium pump does. So by being unable to run the sodium-potassium pump, we get a buildup of ions inside neurons. That edema and excess potassium then can trigger the release of the excitatory neurotransmitter glutamate, leading to the overstimulation of neurons, which leads to sodium and other ions entering the neuron in excessive amounts. And then we then get those excessive ions in the neuron block metabolism in the mitochondria and kill the neuron. So that buildup of ions within the neuron itself is one of the things that causes significant damage. And this happens relatively rapidly. As they say, time is tissue. So if an individual's had a stroke, they need immediate medical care so that they can get treated with drugs that will generally bust the clot. Sometimes surgery is required to go and remove the clot. And then that can help prevent as much of this brain damage as possible. So TPA, which is tissue plasminogen activator, never be able to say that right, breaks up blood clots and can reduce the effects of an ischemic stroke. So TPA goes in and breaks up those blood clots. In the lab, they've discovered that one of the best methods to minimize damage is to cool the brain. And so cooling protects the brain after ischemia by reducing overstimulation, apoptosis, which is the cellular rupture, and inflammation. And so there has been some experimental work on cooling down the individual, putting them into a little bit of a state of hypothermia to cool down the brain. We also know individuals who have drowned in very cold water oftentimes can be revived with minimal brain damage because of that hypothermia. And so there is some work being done to try to minimize that kind of brain damage. Finally, cannabinoids have also been shown to potentially minimize cell loss after a brain stroke. This is primary laboratory research. And so there is some evidence that individuals who smoke marijuana may have some protective benefit of in the brain for a stroke. And that is if they have been taking cannabinoids prior to the stroke. Again, this is early research, but there is some evidence for that, and it's not entirely clear which cannabinoids are the most effective. There are a number of infectious diseases that can have effects on the brain. Generally speaking, bacteria and viruses are capable of infecting the brain and all of its surrounding tissues. There are a number of ways this can manifest. Meningitis is one of the most common. This is an infection of the membrane surrounding the brain. The most dangerous cause is meningococcal bacteria, which can mostly be prevented by vaccination. So you should have all had your meningitis vaccines, particularly college students. Excuse me. As meningitis has a tendency to run rather rapidly through college campuses. Encephalitis, then, is an infection and inflammation of the brain. This can be caused by West Nile virus, which is transmitted via mosquitoes. Can be caused by herpes simplex viruses, which are the varicella zoster viruses. And HIV infection during seroconversion, which is the time at which an individual who has acquired HIV is undergoing what we call seroconversion. That is, the HIV is hijacking their blood, and their body is starting to produce antibodies. And in untreated HIV patients. It's one of the reasons why sexually active young people, old people, anybody who's sexually active should be getting regular HIV tests if you are at significant risk. For example, gay men. There are other ethnic populations, depending on their location, that also have high risks of HIV. You might want to consider pre-exposure prophylaxis, or PrEP, which is a drug called Truvada. All of these are important in trying to prevent HIV infection. Later on, we'll talk about HIV-related brain dysfunction, even in treated HIV patients. So, other infections, herpes we've talked about, Lyme disease is another, rabies, prion diseases, and one of the most significant is syphilis, which is making a dramatic comeback. Syphilis has 3 stages: primary, secondary, and tertiary. Syphilis in the primary and secondary phases is very treatable. That is, you can treat syphilis with a course of antibiotics. Syphilis is kind of running rampant through a number of populations, so it's kind of made a big comeback. Another thing you should be getting tested for And again, it's relatively straightforward. A course of antibiotics will treat that if it's treated in the primary or secondary phases. Once syphilis reaches the tertiary phase, that's when brain damage starts to occur, and that's when syphilis is no longer treatable and is fatal. And it is a pretty bad way to go. It's actually how Al Capone died. Finally, I did want to note prion diseases are things like Creutzfeldt-Jakob, which is more commonly known as mad cow disease in cattle, but can be transmitted to humans as well. Of course, penetrating injury is always possible. This is where we get damage caused by an object penetrating the skull and the dura. We see a few things here. Somebody's had an unfortunate incident with a knife. Then there are a number of instances. Looks like they also got shot with a nail gun. There are a number of instances where individuals have had nail gun injuries and not known about them. Remember, there are no pain neurons in the brain itself, only in the skull and scalp. So once something has penetrated the brain, oftentimes people don't know about it. So damage can be caused by an object penetrating the skull and dura. This can be, of course, a variety of things. Bullets are probably the most common form of this injury. Of course, the famous case of Phineas Gage, in which he had a tamping rod go through his orbital bone and out the top of his skull. There are other cases as well. There's another case of an individual who had a fencing foil enter their nose and pierce their brain and cause instant amnesia. So damage can be caused along the path of this object that's penetrated the skull, as well as due to skull fragments penetrating the brain. And so trying to discern the exact nature of injury is often difficult. Probably the most common form of injury after ischemic stroke is closed head trauma or mild traumatic brain injury or traumatic brain injury. And a closed head injury refers to a sharp blow to the head that does not puncture the brain. One of the main causes of brain injury in young adults, particularly athletes and soldiers and sailors. What happens with closed head trauma is the individual has either had a car accident, been hit in the head, in a football incident, lacrosse, soccer. They've been near an explosive device, so one of the most common injuries in soldiers and sailors. And what happens is then you get pretty significant injury to the frontal lobes, what's called diffuse axonal shearing. And the course of treatment can be slow and incomplete, and there's a lot of work going on in that area. And we're going to revisit that when we talk about brain plasticity and also when we talk about executive functions, because closed head trauma tends to have a significant effect on executive functions. So this is, of course, an area of significant research being conducted by both the Department of Veterans Affairs as well as the military itself, and, of course, sports programs across the country, because we also are starting to understand that there are significant effects if these injuries are repeated, particularly close to one another. And so that's what we call chronic traumatic encephalopathy, or CTE, which is one of the things we talk a lot about with football players. So we'll talk more about that throughout the term. Degenerative disorders include a variety of older age and younger age diseases. Alzheimer's and Parkinson's tend to be older age. There is a younger age onset Parkinson's disease, which appears to have a more significant genetic component, I believe it has a more significant genetic component. Alzheimer's is, of course, degeneration of cognitive functioning. Its physical markers include increases in tau proteins and beta amyloid plaques, or what are known as neurofibrillary tangles. It's unclear at this point which of those is really causing the cognitive disruption, but we will revisit that later on in the semester. Parkinson's is a motor disease, as is Huntington's. Parkinson's is caused by a disruption or loss of dopaminergic neurons in the substantia nigra and the basal ganglia, resulting in reductions in motor functioning. Huntington's disease is also known as Huntington's chorea. It is an entirely genetic disease. Strikes usually in the 30s, I believe, and there is no treatment for it. The best hope for eliminating Huntington's disease comes in genetic testing. So individuals who are concerned about this, if they know a family member who had Huntington's disease, should determine whether or not they're a carrier, determine whether or not their partner is a carrier, and make decisions based on that, because it is a recessive genetic trait, so it requires genes from both parents. Multiple sclerosis is a degenerative disease in which the immune system attacks the myelin sheath surrounding neurons and disrupts neuronal firing. Finally, Korsakoff syndrome is generally secondary to alcoholism. It's actually caused by a dietary lack of vitamin B, in which individuals have lost the ability to process that particular vitamin, usually because of damage to the liver. And as a result, they get significant brain damage and significant memory loss. And we will revisit Korsakoff syndrome when we get to memory. I want to quick run through a few comments about how we study brain-behavior relationships. I'm going to start off briefly talking about structural imaging. We'll detail structural imaging in another lecture. Dip into some cognitive methods for investigating abilities and how that relates here. We'll talk about dissociations and double dissociations, and then some very rare pre-post research that's going to come up in a few areas. So, of course, one of the things we have now is we can image an individual's brain while they're still alive and get pretty good pictures of that. So we'll talk more about this later, but generally this involves CT images or computed tomography, or CAT scans, computed axial tomography, which is simply a series of x-rays used to image the brain. We'll get into some issues about the overuse of CT scans when we get to that lecture. We'll talk about angiography, which is basically mapping out the blood vessels in the brain, then of course magnetic resonance imaging. These allow for precise mapping of damaged areas, allow us to get a pretty good picture of what might be happening. Now, not everything. For example, traumatic brain injury, CTE, that sort of injury is not seen. There's no structural damage because of that diffuse axonal shearing. So structural imaging is not a panacea, but it does allow us to see precisely where a tumor might have been affected, or might have affected where a stroke might have caused damage, that sort of thing. So most cognitive abilities we'll talk about are often what we call hierarchical. So for example, if I'm interested in whether investigating your inability to read, so let's say you have acquired Alexia, which is an inability to read, we're going to want to know where along the hierarchy or along the pathway that is. So if you have disruptions in letter recognition, you're never going to be able to read because you won't be able to recognize letters, put words together, or access the lexical component, or use the context of that lexical component to recognize a word. So first process is recognizing the letters, which is the visual recognition process. Those are combined into words. Still kind of in the recognition category, I should say. Now, if we're talking about reading, we get to word recognition, meaning of that word, and then we might use the context around those words. All of those are part of this process. So if you have disruption in word recognition, what's called whole word agnosia, that's going to be different than letter recognition and also different from lexical access problems. So each of these components we can dissociate or determine based on experimental methods. So we can narrow the possible range of cognitive tasks associated with that brain area and figure out, oh, that's word access, that's where we're accessing meaning, this is where we're using the surrounding words to recognize a word, etc. Now, there's a specialized term we use in cognitive neuroscience in particular called dissociations. So when we get to memory, we're going to talk about patient HM. And patient HM showed us that the hippocampus and the medial temporal lobe structures were associated with long-term memory, that is, his ability to form new memories, but not with working memory. HM had relatively intact working memory and overall cognitive abilities. He could still problem solve, but he just simply was able to form new episodic memories. So what we learned from that is the hippocampus is associated with long-term memory, in particular conscious episodic memories, but it's dissociated from working memory, and that's a dissociation. So the hippocampus has been dissociated from working memory. because we have damage to the hippocampus, but we don't have any loss of working memory. Now, a double dissociation would be something like Broca's aphasia and Wernicke's aphasia. That is, we have in Broca's aphasia, we have a loss of the ability to form spoken words. In Wernicke's aphasia, we have an inability to understand spoken words. And we have individuals who have both of those different types of aphasia. And so we can double dissociate understanding spoken language from producing spoken language and the brain areas involved. Finally, I want to get into some rare pre- and post-research issues. The first thing we might get into with individuals with brain damage are those that are undergoing some sort of surgical intervention. Usually, this kind of individual would be part of research studies involving, say, patients with epilepsy and have a very specific type of surgery. So split brain patients, for example, this isn't really done much anymore, but it used to be you might split the corpus callosum between the hemispheres of patients to try to solve their epilepsy. We can, with those kind of patients, look at their abilities before and after surgery. There are other forms of epilepsy surgery which are less invasive, involving fairly small parts of the temporal lobe, for example, but we can look at their abilities before and after that kind of surgery. And then another example comes up with electroconvulsive therapy, and again, not used that often, but often enough that this allows for some interesting research. Essentially what ECT is a scheduled brain injury. And so as a result, we're able to quantify more accurately what happens when you have that kind of brain disruption. And in fact, we're able to quantify temporally graded amnesia in a pretty amazing way. And temporally graded amnesia is this finding where we get loss of memories surrounding an injury, both before and after an injury. So the loss of memories prior to that injury are what we call retrograde amnesia, and the loss of memories after an injury are anterograde amnesia. And most patients lose a chunk of memories sort of both before and after. And there's going to be some important lessons we'll learn from that particular finding. All right, that's a quick review of brain disruptions and disorders and some of the things that we're going to be studying in those populations later on in the term.